Hi, I'm Em Rusciano. I'm a writer, singer and stand-up comedian. And perimenopause is kicking my ass. So I decided to do something about it. This is Rage Against the Vagine. Perimenopause isn't just a personal struggle, it's a system failure. From medicine to workplaces, the structures meant to support us weren't built with us in mind. And it's time to change that.
We do more than give a shit. It's in a whole range of areas. It's in women's safety. It's in leadership and decision making. It's in, access to healthcare. It's access to housing. We've got to smash the patriarchy.
Leaning in isn't going to fix things. We have to do some structural change.
This is what's behind the huge gender pay gap that's evolved in general practice.
We want to look at developing a tool, a better and more culturally safe diagnostic tool that gets used with Indigenous women, that is designed by Indigenous women.
We're doing a lot of our research on a shoestring and we're super stretched.
I want a menopause and Me Too moment.
Rage Against the Vagine is proudly brought to you by What If. It's Aussie for travel. Rage Against the Vagine was recorded and edited on the traditional lands of the Wurundjeri Woiwurrung people of the Kulin Nation. We honour the cultural strength, sovereignty and resilience of all Aboriginal and Torres Strait Islander peoples and acknowledge their continuing connection to land, sea and community.
My vision is to live in a world where women's experiences are acknowledged and respected, that we're not dismissed.
I'd like some more training for our GPs so that they have a better understanding.
I would like to be heard, believed and helped.
And not dismiss us as being too emotional or too young or not actually needing any help when we need a lot of it.
Funding or money towards hormone replacement, so it is not a ridiculously exorbitant thing to manage.
I would like to see an increase in the knowledge and understanding throughout the whole medical system so they're able to provide us with the most accurate and individualised care and support that not only we need, but we bloody deserve.
Welcome to episode 6 of Rage Against the Vagine. And it's the big one. The one we planned on ending on, but now we have several more projects in the works. So we'll just say it's the big one. The one where we tackle the question, how do we fix the f***ing systems? That opening montage, that was our Rage Committee. 1,000 women and AFAB people who have set the tone for this entire series. And now they're setting the vision for a future where their experiences are acknowledged and respected, and they're given ready access to the help they need. Quick reminder, I met with 20 plus experts, some I even sat with twice. We distilled 15 hours of interviews into a 6-part toolkit to arm you with validation and seeds of knowledge to better navigate perimenopause. The who, what, when, where, how, and now, what the we can do about it. Across episodes 1 to 5, we kept hearing it. Medicine, research, education, workplaces, family structures, and social attitudes weren't built with us in mind. So here we are, Season 1, Episode 6, the Fix It episode. You might be thinking, where do we even start? When in doubt, crack open the history books. Because every big shift begins with a change in how we think about the problem. Albert Einstein, you know him, the physicist who rewired how we see reality, nailed it. The world as we have created it is a process of our thinking. It cannot be changed without changing our thinking. Huge from Albie. Can I call him Albie? Too late. Point being, post-reproductive health for people with ovaries needs a full rethink. Systems don't fix themselves. They shift when enough of us refuse to stay silent and make our problems impossible to ignore. So I bundled up as many of our problems as I could carry and took them straight to someone with the power to shake things up. Senator Katy Gallagher, Federal Minister for Women, Finance, Government Services and the Public Service. But before unloading, I played Katy the Rage Committee's 3 words to describe perimenopause audio compile and asked her for 3 words, as a little icebreaker.
Confusing, chaotic and difficult.
Yeah. I mean, they're very polite words.
I tend to be polite.
Listen, there's nothing polite about perimenopause.
No, you're right. But I think those three would be the ones that are for this, for public usage. But I would have a range of other words. You only gave me three, and so I started polite. Who knows where it would have ended?
Don't worry, I will smash through Senator Katy's politeness defences before this chat is through. But first, I had to ask, as a policymaker and as a woman in midlife responsible for shaping policy for women, why does she think perimenopause and menopause have been so invisible in our health and education systems?
Like, it's hard to pick a final or a one specific reason. I think it's probably a combination of a number, and I don't think we get prepared as, we get kind of educated into a point that we're prepared for when it happens. And some of that is about the medical system and, the way that that's been built over time and, the misogyny that is built into that system, which is structural. So it's partly that, but it's also, I think, community attitudes and, the world we live in where gender equality is not a thing yet. I think when you do a lot of testing and research, a lot of Australia thinks we live in a gender equal society, and that's a problem in itself because we know that that's not the case. So I think it's a combination of all of those things. But, it's an area I sense in my time in public life, it is changing, and it's changing for the better.
What do you think it's going to take to close it, though, in terms of, especially with the medical misogyny, not being believed, being given antidepressants, also, not getting long enough appointments, female GPs being punished for taking the time with patients that male GPs don't. And the medical misogyny affects the GPs too, not just the patients. I'm an autistic person, so I like to understand systems and I like to trace things all the way back down to the beginning. It's the patriarchal system. It's the industrial revolution. It's the way that everything's been set up to suit a 1950s white businessman who at home has a cook and a curator and a cleaner and a chauffeur and childcare, and nothing's set up for us to succeed. And I don't know how we close that gap because it is so baked into our society. Do you know I know you know what I mean. You work in politics, and I know you're a politician, and I know it's hard for you to answer these questions from your gut, like I can see you want to, but I'm asking on behalf of all these women in AFAB that are just looking out desperate for help and understanding and societal change around this issue.
Yeah, totally agree. And I don't mind answering from the heart, not talking points. Again, I wish there was one thing that we could do to solve a whole lot of issues for women and girls in this country. I wish there was, but I've kind of come at this, I'm looking at it, and for me, it requires us to systematically challenge and break down all of those structures that you're talking about that were embedded, and we know about it. But it's not just in health, it's in a whole range of areas. It's in women's safety, it's in leadership and decision making, it's in access to healthcare, it's access to housing. There's a whole range of things where we've got to kind of go one by one and dismantle. A lot of people say, we've got to smash the patriarchy, and that's a great line to use, and I've certainly used it in my time. But, doing that actually requires some hard, careful work. It requires money from government. It requires community attitudes to change.
Quick pause here. Senator Katy is in full stride, and she's about to pivot to what she can actively control. But before we move on, this part about community attitudes changing, that's where the real work begins. And it starts close to home. Real close. Oi, you listening, I'm talking to you. Here's your first piece of homework. I'm so sorry for saying oi, that was aggressive, but I wanted to get your attention. Remember what I said off the top about needing to change how we think and reframe narratives if we want real change? Exactly. Because these broken systems aren't just clear-cut policy issues. They're rooted in the patriarchy that seeps into our workplaces, institutions, and even our homes. It's in the way we put pressure on ourselves, excuse certain behaviours, or assume who should care, who should lead, who should stay quiet. That's internalised misogyny, and whether we notice it or not, we all carry some of it. So if you're listening and wondering, what can I do to change the fucking systems? Start there. Notice it. Call it out when you see it. Reflect on where it shows up in your own thinking or in the cultures around you. That's how community attitudes shift, with one uncomfortable conversation or one refusal to play along with the old script. Okay, sorry, Senator. You were about to say what you focus on.
I focus on the things I can control the most. And in this area, it is built on the work that Jed Carney did when she did a sort of a big kind of focus on medical misogyny and how we come at it. What do we change? How do we try to deal with some of that? And that's why you've seen, I think in the last budget, we had a big focus on women's health. It was around longer appointments. It's around listing of medications on the PBS. They hadn't been updated for 30 years. In menopause treatments. No new menopause treatments had been added to the PBS for 30 years. Like, that to me is nuts.
Yeah.
Same on the contraception side. It was slightly less, I think about 20 years for the modern pill, which has less side effects and is better for women, but hadn't been listed on the PBS. Again, not right. And so, coming at it from a whole range of different ways, training for GPs, absolutely essential. We've put in a specific a longer Medicare rebate for women's health and for, women to have that longer consult and the rebates to be higher. So that encourages the GPs to do that longer consults because, consults have been a problem, consult times. And so we have changed that, and that's been running alongside the listing of treatments that we've done.
So, as Senator Katy's been saying, the Labor government went hard on women's health at the last election, and it's already shaping policy. Now, across this episode, you will hear from Katy directly, but also you'll hear me read some statements from her office because we had some important follow-up questions after my chat with her. One such follow-up covered the biggest pain points you heard about last episode, which was the lack of GP training for perimenopause. So I asked her office to spell out what's exactly being done, and here's what they told us. The training Labor has funded for GPs covers both perimenopause and menopause, and that government funding makes those courses free for GPs, nurses and midwives. And these courses may count as part of their yearly continuous professional development requirements. See, it's not all doom and paperwork. Free training that ticks the CPD box and means you'll actually know what to say when a woman in perimenopause bursts into tears into your office because she's convinced she's losing her mind. Doctors, nurses, do it. Sign up. Future you and future patients will thank you. And it's not just about what happens in medical classrooms. The minister's team told us Labor will be releasing the first ever clinical guidelines that we don't have yet, and a national awareness campaign that covers peri and menopause, finally dragging perimenopause out of the shadows and into the spotlight. Again, I'm just pointing out we don't have that yet, so let's make sure we hold them accountable. Okay, put a pin in that one. Someone who's been pushing for our post-reproductive health to be taken seriously for years is Dr. Kelly Teagle, founder of WellFem. So, of course, I wanted her take on all of these new initiatives.
In one fell swoop, the Albanese government has done more around women's health than any government's done in, a decade at least. And so we're all very excited to hear what the details of that were. I think the single most powerful thing out of that for us in peri and menopause at least has been the funding of the new PBS items, so that's helped so many people, just incredible. It's hard to underestimate that. And there's things that have to go on in the background to support that now, like fixing the supply issues that actually will get, the patches to everyone who needs them and things like that. As far as the new Medicare item goes, again, we were very excited to hear about that as well. But it was like, so how much is this rebate going to be and what conditions are they going to put on that? For somebody who works in this area, and I think most subspecialist GPs who work in peri and menopause will agree that you kind of need, 40 minutes to an hour at least to do a decent menopause assessment. And at the moment, the way Medicare is structured is it's very time-based. So for a GP doing a consult, you've got these brackets of time. So anything up to 6 minutes, and then a 6 minute to 20 minute, and then a 20 to 40 minute, and a 40 to 60 minute, and then anything over 60 minutes. So these are like how it's chunked up. But the problem is that it's front-loaded. So if you're doing lots of short consults, you're actually earning heaps more money than if you do one long one. As an example, if you were doing 8 7-minute consults, total 56 minutes, you'll be earning 3 times more money than if you do a single 56-minute consult if you are bulk billing those patients. Now, that's a real problem for women GPs particularly because, people used to laughingly say that female GPs do all the tears and smears, which is actually very true. It's all the mental health stuff. It's all the women's health stuff, the stuff that actually takes quite a lot of time. And this is what's behind the huge gender pay gap that's evolved in general practice, because the women doctors are the ones that the women go to see for all of that stuff. Whereas the male GPs, I'm generalising a lot here, of course, but the male GPs largely are doing these quicker turnover. Yep, what problem have you got? Here's a script, right next, and they're seeing more and more patients in that time than a woman doctor would see. So there's this massive gender pay gap and, there's no incentive for doctors to want to do the longer consults. Now, we all thought, great, this, new Medicare item is going to help to solve that problem because we'll get more money for doing the longer consults. And I know that's the thinking behind it. But at the moment at WellFem, we're billing the 40 to 60 minute item number to do our consults, and a patient will get $125 back for that consult. And if they were doing the next level down, which is the 20 to 40 minutes time-based, it's usually around, I think it's $83 rebate. Now, the government has set this menopause assessment item as around $102, which when you kind of look at it, it sort of seems to be geared at the 30-minute mark in terms of being consistent with the current time-based system. And that's just not long enough. I really think that we need to see a tier higher so that we can be getting higher rebates for the 40-minute consults, maybe $200 or something that really encourages GPs to put in that extra time. But, I think what we've got here is that if GPs are going to be billing the Medicare item for the menopause assessment, it's going to be rewarding those who are doing closer to 20 minutes because they can do more of them in an hour for more pay, but still doesn't benefit the patient. So it's a really tricky area because I think that if a GP is doing between 20 and 30 minutes on their assessment, then they will probably use that item. But for us and other specialist type GPs, we're not going to be using the item because it's just not enough for the length of time we put into these consults.
I said it in the last episode, 20 to 30 minutes per annum spent on this is simply not long enough. Especially when the specialist GPs, the ones who actually take the time, usually spend at least 40, closer to 60 minutes with their patients. And by the way, are paid less and punished for caring. Patriarchy much? We'll come back to that. Because there's another big gap in the new Medicare menopause health assessment. Telehealth is excluded in this first rollout. That means people who rely on it for access or for privacy may still be left out.
When I first heard about the new item numbers that were going to be brought in for peri and menopause, I didn't dream for a moment that they would be restricted from being able to deliver by telehealth because there's been this really good recognition through COVID and beyond about the value of telehealth to deliver quality medical care for sure. And as we're proving every day, quality menopause care as well. We've got this subset of sexual and reproductive health Medicare item numbers that don't rely on a previous face-to-face relationship with the patient. And so that's been amazing because it means that there's no barriers to locality or privacy, that women, if they can't find a doctor they're comfortable to go and see in their local area about their sexual and reproductive health issues, that they can actually go further afield, including telehealth. And that's the whole point of it, especially if there's geographic restrictions. So, of course, we just assumed that when this new Medicare item for menopause was coming out, that's part of the reproductive and sexual health spectrum. So, of course, you're going to be able to deliver by telehealth. No, apparently not. So that's a real bummer. It does mean that patients do have to find a local doctor, which is part of the problem in the whole first place, isn't it? Is that they can't find a local doctor to be able to deliver that care. That's why they go to telehealth providers like us. So now they're limited to being able to only see a local health provider who they've seen in the last 12 months to deliver that item. So that, to me, is a big problem. And I think this question was actually asked in, was it Senate? Yeah, I think it was asked in Senate estimates, actually, as to how they decided what the amount would be and what conditions would be put on that. And the answer was, we haven't had time for consultation.
Sometimes that's the trade-off between progress and perfection, but it does mean important voices weren't heard. We had to go back to Senator Gallagher on these gaps and what Labor plans to do about them. From her office. The reason the MBS menopause health assessment is generally not available via telehealth is that one of the requirements of the item is a physical examination. This is me breaking in on nobody touched me in my assessment. Why the hell do we need a physical assessment when most of the manifestations are mental for us? I don't understand this. Okay, back to Senator Gallagher's response. Wait, am I allowed to officially break in on someone's statement? I have. Back to my official statement reading response voice. The MBS menopause assessment items are available once every 12 months, not long enough. In between times, women can access ongoing assessment and treatments via Medicare, including face-to-face and telehealth consultations, ranging from short, simple consultations to complex consultations lasting longer than an hour. Since starting on 1 July, more than 23,000 women have accessed a menopause health assessment. Oh, good for you. I love that. The items are also encouraging GPs to proactively engage with their patients on menopause-related issues and to upskill in menopause care. About time. Oh, that's me, not Senator Gallagher. We haven't got her to swear yet. Don't worry. It's me. What do you think happened? Okay, back to Senator Gallagher's statement. We know there is more to do, and your listeners might be interested to know that the MBS health assessment services generally, including the menopause health assessment, are being reviewed, and this will inform how the menopause health assessment works from mid-2027 onwards. That's a long way away. That's a long way away, Senator Gallagher. I don't know that I'm supposed to be giving director's commentary on a politician's statement, but here we are. There will be public consultation as part of this review. We're essentially turning around a big ship when it comes to properly supporting women to access perimenopause and menopause care. That means making sure symptom management and treatment are part of the everyday healthcare women receive. This shift requires many parts of the system working together, and as each change comes online, we'll see that ship turn more quickly. The menopause health assessments will sit alongside our investments in awareness, education, and training programs for perimenopause and menopause. All of this is backed by our broader efforts to strengthen Medicare, reduce the cost of medicines, and build a stronger primary health workforce. It's a work in progress, and we'll keep listening to women and fine-tuning the health system so it actually works for them. Look, if we're calling post-reproductive healthcare a ship, then perimenopause has been stuck in steerage for decades while the men have been up on the captain's deck. It's time to move us out of the cargo hold and give us a bloody lifeboat. Huge thanks to the Minister for Women for the chance to follow up on these important points. And with public consultation on the horizon, we've taken the liberty of collecting the first feedback form. Here is Dr. Kelly Teagle's 3 wishes.
Number one, I would definitely make the new Medicare item for peri and menopause able to be delivered by telehealth if a patient can't find a doctor locally that is willing or able or that they trust to do that for them. Number 2, I think I would like to see another tier to that Medicare item number so that because at the moment there's no advantage to GPs using that item number if they're going to be doing consults of 40 minutes or more like we do. They need to have another tier of that rebate available or actually have it delivered as part of a GP chronic disease care plan or a GP management plan, because menopause isn't really a chronic disease, but it does mean that people have a higher risk of developing chronic diseases if it's not managed properly. The other thing I think, and we haven't mentioned this yet, but I'd actually like to see the ability for subspecialist nurses under GP supervision to be able to do prescribing in this area, because there's just not enough doctors who are experienced and well-educated and menopause informed. But for example, we've got a nurse who's fabulous at this work, but she's unable to prescribe. And there are no specific Medicare rebates available if you see a nurse instead of a doctor. So we need more subspecialist nurse item numbers so that nurses can do some of these consults under supervision of specialist GPs.
Spoiler alert, we went ahead and sent these suggestions to the Minister. Yes, taking full advantage of our access to her direct office. We may be having those privileges revoked, but it was worth it. And here's what her office told us. From 30th of September 2025, suitably qualified registered nurses will be able to prescribe medicines to treat peri and menopause where they have a prescribing agreement with a GP or other authorised health practitioner. I love that. Anything that improves access and choice for women and AFAB people gets a big tick from me. I also loved Dr. Kelly's vision of a system that actually treats the whole picture with a management plan and not isolated 12 monthly checkups. Oh, and yeah, I'd love a system reset that stops punishing the doctors who care and actually give us the time and attention we need.
It's a known fact that female GPs earn less because they spend longer with their patients.
And to provide that care means we also get paid a lot less for what we do. And when we're talking about menopause care, it is really, really important that that is valued.
And it is an important gender divide that I think isn't being talked about enough, because I don't think anyone wants our female GPs to not be showing up and doing what we do.
See how women are being shafted again? This is the patriarchy at work in plain sight, and it's exactly the kind of system I want you to notice and start questioning. And this isn't just across the healthcare system, it's about how women's work is valued across the board, which makes the perfect segue to where Senator Katy and I went next.
We have to keep plugging gender equality. So, some of the changes we've made about women's work and the pay that women get, PPL extensions, paying super on PPL, what we're trying to do there, you can't see it in isolation of health, because what we're trying to do there is in other areas build up respect for women and the respect for the work that women do and the role they play as carers, predominantly as the caring side of the economy, whether that be in paid employment or for children or older people. And all of it's interconnected. I know that you don't necessarily look at it and think that that's the case, but for our government, it's around driving gender equality from the centre, and because we've got to fix up a whole range of things.
I really appreciated this from Senator Katy because, yeah, the medical system has its flaws, but the bigger issue is how little we value the role women play in workplaces, in households, in the economy at large. And there's a real cost when those spaces don't make room for women and AFAB people in midlife. Enter our workplace specialists, Grace Malloy from Menopause Health Australia and Will Strack from the Victorian Trades Hall Council to drop some knowledge.
So $21.8 billion is the estimate of what it costs to ignore menopause and menstrual health concerns in the workplace. It's a huge amount of productivity that we're losing.
Women are retiring 7 years earlier than men, and we know that they're retiring 12 years earlier than they want to.
The Australian Superannuation Funds Association did some research last year, and they found that it costs about $60,000 to a woman's retirement savings because of menopause, scaling back, going into casual work or scaling back to part-time.
I'm sure you have thoughts, Senator Katy.
I think the big issue there, when you look at it, the economy-wide impact of that, is we already have underutilisation of women across the labour force throughout, really from once you're, in your early 20s. You're kind of ahead of boys in your teenage jobs, and then once you get into that adult years up to retirement, we start lagging behind. Some of that's explained by having children and the cost that imposes on individual lives, particularly women. But it also means that our economy isn't as strong or growing as, in a way that it should if women who wanted to work the hours they could work were able to do so. And again, that requires us to fix early childhood education and care. It means better paid parental leave. It means better pay and conditions when you are at work, which is why we've been trying to deal with aged care workforce and early childhood educator workforce, because they're 90% women and low paid, undervalued and under-recognised for too long. So we've got to deal with wages, we've got to deal with conditions.
Speaking of conditions, Will is part of the team advocating hard for the Everybody Matters campaign and would love to see reproductive health leave brought in.
So what the unions have done is they've negotiated for two things. One is leave, specific leave, because 10 days of personal leave, which is what most people get, this is for illness or for urgent medical issues. This is not illness. Being perimenopausal isn't illness. It's a life stage. Yeah. So we say, therefore, but it's a life stage that we know, for instance, that women are retiring 7 years earlier. And we also know that for women under 55, ill health is cited by around half. And you would expect that to be around the same for women over. It's not. For women over 55, that halves. So we're saying that half gap is clearly related to something that's happening for women.
I wonder what it could be.
Exactly. So we go for time off, but it's for all reproductive health issues. So there are women, for instance, with endometriosis who have terrible periods. It's time off for that, right? Up to 12 days a year.
Yeah,
so
right.
it covers things like, as I say, endometriosis, pregnancy loss, hysterectomy, vasectomy, a whole range of conditions, including the symptoms of perimenopause. The thing about that the reproductive health leave claim for me is also that it's about that conversation about how do we restructure workplaces so that they are actually, rather than people having to squeeze into a box and fit a thing, we actually understand that everybody has issues that we need to work around, and workplaces that actually work around where people are at are more productive.
Grace is all for workplaces having productive conversations. In fact, it's at the centre point of all the great work Menopause Friendly Australia does. But on the matter of mandated leave for reproductive health,
I'm so torn on this one. It's a really hard thing to justify because, when I speak to my partner about it, I say, look, just because I'm born with ovaries means there's going to be things that happen to me throughout my life, many more things than will happen to you that might mean that I need to take time off or go to appointments. I did IVF to have my kids, I did fertility treatment for 3 years. I know what that's like, using up all your sick leave. So I think personally, I can absolutely see the argument for it. My concern, though, is we have so many small and medium businesses in Australia, and I really, when I talk to some of those business owners and I ask them, would this be a consideration if you had two candidates and there's mandated leave for reproductive health and you had a male candidate and a female candidate, would you, in the back of your mind be thinking, well, I'm probably going to have to give that person a lot more leave days than that person because the men are probably not going to use it so much. And I really don't want any more barriers put in place for gender equality. So I think what we're seeing is that workplaces who do understand that providing a supportive environment is actually going to be good for business, they're getting in the front foot. They're really role modelling what it looks like. And so I don't believe that we do need to mandate leave. I think we can show what it looks like when you give leave, and it's a really great experience, both from those people who need it, but also from a productivity perspective, rather than going ahead and mandating 10 days or 12 days. There was a report recently by the Bank West Curtin Economic Centre that looked at how much it would cost to provide 12 days leave, and it's if you look at the cost and then the benefits, the gross cost is quite significant. But when you reduce the benefits, it ends up being about $140 per employee per year.
I think the government should fund it.
Maybe the government should fund it, and then workplaces don't, employers don't have to fund it.
Yeah, I believe that. I think so. I think the government should fund most things. I wonder how our Minister for Finance feels about that.
I think our personal leave arrangement should be able to accommodate a whole range of leave. I think the minute, and this might be controversial with some women in particular, but the minute we start setting prescriptions about certain leave for different types of things, you exclude somebody who needs leave for a different kind of reason. And that's why we moved away from personal leave being sick leave or carers leave, and we combined it into personal leave. And so some of the thinking I'm doing across government is, sure, menopause leave and reproductive care leave, all of that should fit into, in my view, into your personal leave entitlement. And there will be, other reasons why others outside of caring and illness and other things will want leave. But I am worried that you start prescribing and you exclude, which is the whole point behind having good personal leave arrangements that don't come with a lot of strings attached.
Once you start mandating things, unintended consequences creep in. Rules don't always land the way they're meant to. There are taboos to work through, the risk of discrimination, people gaming the system, clunky admin, costs, and for the government, the big one, opportunity cost. What gets cut if this gets funded? And I do get why small businesses, already stretched, would feel nervous. If you're running a cafe with 6 staff, the thought of more mandated leave probably makes your stomach drop. But the more I sit with it, the more I think, why not call reproductive health out for what it is? Unpredictable, distracting, and often debilitating. And if leave through this stage of life isn't mandated and we're just relying on workplaces to do the right thing, I think we're in strife because we know what business is like. Mandating it puts it in the vernacular. It normalises it. It stops being whispered about as a woman's problem to quietly endure. That's what Will's talking about. Unions fought the same fight with family and domestic violence leave. For years, it was buried under silence and stigma, and making it a workplace right dragged it into the light. I think that this kind of leave should be done on a sliding scale depending on how big the businesses are, but I'm not a finance person. So I sit squarely in the middle of this, and I think there's nuance, and I think two things can be true at once. But I do think and acknowledge that there are huge risks, but history tells us that if we wait for workplaces to voluntarily do the right thing, women and AFAB people will be waiting a very long time.
So in 2010, I was at the Australian Services Union and we negotiated a world first family and domestic violence leave clause. And we did that for 2 reasons. One is we know that one of the prime reasons why women who are experiencing family and domestic violence fall into poverty is that they lose connection with their jobs. And the majority of them are working. So they lose jobs. That's a bad thing. The other reason we did it is because it allows us as trade unions to have conversations in workplaces with workers about what family and domestic violence is, how it impacts on work, and why it's important in the workplace but more broadly in society that we fix this. So for us, doing these kinds of campaigns and claims is not just about the practical impact it has on the people who will take the leave or who will ask for the accommodations. It's about reducing the stigma because everyone's then had a conversation about why it's important.
I think that this kind of leave should be done on a sliding scale depending on how big the businesses are, but I'm not a finance person. So I sit squarely in the middle of this, and I think there's nuance, and I think two things can be true at once. If you want to know more about the Everybody Matters campaign, check out the show notes. And if you're curious about what proactive, productive workplaces are doing differently, take a look at the Menopause Friendly Australia resources. Because workplace change is about more than just leave. It's about safety, it's about flexibility, it's about creating environments where women and AFAB people can actually stay and thrive throughout all life stages. I mean, I had to create my own business just to make a workplace safe enough for me and my family. So I wanted to hear from the Minister for Women on what role government has in pushing workplaces to change for women and AFAB in midlife.
This is something in the public service where I think we can lead. That's why we fought really hard to protect flexible working arrangements for, the recent election campaign when it became such a big focus was, if we're not making workplaces work for women, you won't have them. Like they will not engage, they will not come to work or want to work the hours that you want them to work. And so as an employer, you have to be accommodating, amongst other responsibilities. And, whether that means like working from home arrangements or you're coming in later or leaving earlier, these are standard arrangements that I think any employer needs to be thinking about. Otherwise, they're not going to retain, we're in such a global kind of search for talent in Australia, like in other countries, that unless you're going to be accommodating and supporting your employees and they will repay that through loyalty, you're going to be in strife.
Senator, I have to ask you, does your own high-stress workplace offer proactive support for women and AFAB staff in midlife? Look me in the eye when you answer.
Well, I'm sort of more fortunate than most. When I think about my workplace, we're trying, it hasn't traditionally been the greatest workplace in the world, as people will have read, no doubt. And so we have been trying to do a whole range of things to improve the workplace and to make it a more respectful workplace and to stand up against sort of hate and misogyny and things like that. But there's, still some of that goes on in this building. I'm I'm not really an employee, but as a worker who comes to work every day, I'm probably a bit more fortunate than most in that I have a bit more control over my diary and things than many workers have, and I'm really conscious of that. But this is, this workplace, out of all the workplaces, should set the standard for how people are treated. And that's what we're desperately trying. We've done a lot of work in the last 3 years. There's a lot more to be done, but we have managed that across all the, different parties and interests in the parliament. But yeah, I have no doubt it can be better. It takes a long time to get, things like breastfeeding spaces and all those kind of supports in a workplace like this that was, as you say, it was built for men, probably older men, who had previous careers. This place is inundated with young women now. Like in our caucus, 56% of our party room are women, and many of them are women younger than me, partly because I'm getting so old, but also we are attracting really young women into politics, and that's changing this place. So babies are on the floor. There's a childcare centre here. There's parental leave arrangements. So male MPs and senators can actually legitimately take time away from the chamber to be there, to be a parent. None of that used to happen. And so we are moving in the right direction, but there is definitely more to do.
All this talk about workplaces bending and flexing got anyone else daydreaming about an actual escape? Same, babes. Because let's be honest, sometimes the only way to protect your peace is to literally leave the house. Step away from the bills on the countertop, the washing pile, the never-ending what's for dinner loop, especially when you're in and out of brain fog, bone-deep fatigue, or a full-blown rage spiral. That's where What If comes in. They actually make it easy to carve out time for yourself. Whether that's a cheeky weekend away, a road trip, or a staycation, with simple search tools on whatif.com or the app. Plus travel tips, tricks, and seed-planting blogs like quick escapes, hidden gems, or even how to stay bougie on a budget. Because sometimes the best way to find the forest for the trees is to book yourself an escape into an actual forest. So if you need a peripause, jump on whatif.com via the show notes, where you'll find some info about our discount code, and start planning. Seriously, think about it. I've been saying it all series because it matters. Please make time for yourself, and not just scraps of time, not what's left over after everyone else, actual intentional time that's yours. You are allowed to prioritise yourself. I'm giving you permission to. Remember, you're only a what if away from protecting your peace. What if? It's Aussie for travel.
I found menopause has really increased my pain, just to a point that I can barely function, and I don't know how to talk about chronic pain because I've got a disability. No one can really help us. You got a pain specialist. They kind of look at you and go, well, of course you're in pain. You have been pushing a wheelchair for 30 years.
Trans and gender diverse people's voices generally across the healthcare spectrum are often invisible, unheard, or just outright dismissed.
We need to capture the stories of Indigenous women. We absolutely need to, and there needs to be more research done into this, and we need better funding for this. We want to look at developing a tool that helps actually a better and more culturally safe diagnostic tool that gets used with Indigenous women, that is designed by Indigenous women.
We're doing a lot of our research on a shoestring and we're super stretched. So to have more funding put into sort of women's mental health and women and neurodivergent women in particular.
If there's not sufficient studies, awareness, and it's not taught to doctors, how are we going to help women?
You've heard these voices across the series, the ones usually left out of the perimenopause chat. People with disabilities and chronic illness, LGBTQIA+ community, Indigenous women, neurodivergent women, Carney, Dr. Karen, Professor Odette, Associate Professor Caroline, Dr. Fatima, they've all pointed to the same thing, massive research gaps. And here's what really freaks me out. Look at what's happening in the States under Trump. They've slashed women's health research, shut down diversity and inclusion programs, even tried to kill off long-running women's studies. Whole areas of knowledge just gone. So against that backdrop, I asked Senator Katy Gallagher, if the foundations are this shaky here and overseas, are we doing enough in the research space?
I don't think you'll ever be able to say you're doing enough in the research space, but we are not taking our lead from the United States. We've got the Medical Research Future Fund here. We've made some decisions about that in terms of, there was terrible problems with women being very unsuccessful with their research projects that they applied through that fund. So we have changed those arrangements now. So more women, women are getting their fair share, so an equal share of that research, so for women researchers, and that is changing the nature of what that's funding, of course. It's just like when you put more women into something, you will see a commensurate increase in research that relates to women. So we are seeing that, and certainly we are keen to fund. I think AIHW we've given some money to do a lot more research in this space and women's health in particular. But yeah, there's always more to be done.
So what can you actually do? One meaningful thing is to put your hand up to participate in these studies. I mean it. Research on things affecting women and AFAB people only moves forward if women and AFAB people actually take part. Associate Professor Carolyn Gervich at Monash University's Her Centre has studies coming up on perimenopause and neurodivergence. Hello, core emsolation audience. And keep an eye out on other reputable sources too, like WellFem, Jean Hales, and the Australasian Menopause Society. But it's not just about volunteering. It's about being informed and pushing these priorities. Like right now, the PBS is deciding whether to add new menopause treatments, like testosterone for women and a non-hormonal option for hot flushes. WellFem's calling for submissions, and your voice really can change access. Link in the notes. And beyond being informed and actively participating, stay f***ing loud. Support the groups lobbying for more. Write to your MPs. Keep asking the questions. Where's the money going? Who's getting funded? And are female researchers backed? Because the louder we are, the harder it is for policymakers to look away. Now we've covered the medical systems, workplaces and research gaps with Senator Katy Gallagher, I had just one more question. On behalf of each of you, direct to our Minister for Women. Before I let you go, Senator, and I want to take away something very real from my chat with you, because you are the most powerful woman in the country that I can access that can make a real change, and to have your ear is very important to me because I'm very protective of my audience who are so vulnerable at the moment because I hear from them every day. And I guess I will ask you, as a human person who's gone through this, if there's a woman or a member of the AFAB community, she's listening to us chat now and she's deep in the trenches, feeling unseen and unheard and uncared about, what would you say to her? And I ask you to speak from your heart just for the moment, because I know this kind of shit can make a difference to people's lives.
I would say to her, firstly, that she's not alone and that there's so many of us that feel that same feeling that she would be feeling. And so that would be the first thing, because I think that being alone and feeling sort of frightened and confronted and thinking you're weird or that it's just something with you is very, very distressing. So you're not alone, and it is hard. Like, I don't think there's any pretending that going through this stage of life is going to be easy, or that there's, you know, a single tablet that you could take that will just get you through it and you'll wake up in 10 years' time and it'll be all fine. But that there is a lot of help, and there is a lot of, you know, to reach out to other women, and there is a lot of effort going in to make sure our care and support for women going through perimenopause and menopause is improving all the time.
And you can say that her government gives a shit about her?
We do more than give a shit, because I think it's easy to say you give a shit. It's harder to say this is what we're doing about it. And we are doing things. And I've had because this is a really, you know, it's such a difficult time. And like I said, I've gone through it. Like, I know exactly how people, you know, because I felt like every other woman feels like, and I know some people have different impacts and all of that. So I'm not trying to pretend it's a one size fits all. But I've had, you know, just down at my local chemist, when we listed the new treatments for menopause, people grab me and go, this is like life-changing for me. Not because they weren't taking the treatment before in some cases, but because they don't have to pay through the nose for it. Because that's the other thing, that women, through medical misogyny, women have paid more to get access to the help that they need. And part of what we're trying to do, so yes, we give a shit. And as part of giving a shit, we're also trying to change the system for the better. And there's a lot more work to do. And we rely on you, Em, and your listeners and all of those people in your community to keep, you know, giving us a kick up the bum to get it done.
Did you hear that? I told you I'd get her. Yep, Senator Gallagher finally swore. But more importantly, she extended a standing invite to keep our pollies honest, with a kick up the arse whenever they need it. And honestly, I believe her. Senator Katy Gallagher, our Minister for Women, Finance, Public Service and Government Service, a hard-working menopausal mum who knows change only happens if we keep making noise about what matters. Her start and end point was simple: respect for women and the roles we play. Because for too long, the positions we occupy haven't been valued. And when you're not valued, you're not invested in, researched, supported, serviced, or even paid properly. This podcast has had a more narrow but urgent project, validating and arming women and AFAB people with knowledge and tools to survive perimenopause and thrive in a spectacular second act. But Katy and her team have to pull at the bigger threads, the patriarchal systems and the lack of respect baked into them. That's where your help is truly needed in fixing the f***ing systems. Set standards that demonstrate respect and make sure you're intersectional with your feminism. Help lift up those without a voice. I know it sounds huge, but it starts in how you show up, how you set boundaries, how you value your time, and how you protect your peace. You can do meaningful things in your circles of influence as well. I'm talking at work, in schools, in your community, and especially at home. Speaking of home life, I asked the Rage Committee to validate my theory that education is needed in schools for our kids. I put the call out to see what the baseline was, what their kids and teens knew about perimenopause. And fucking hell, there were some big surprises. Like, to be honest, this was the sentiment I was expecting from most of the young people.
I don't know about it, no, sorry, I don't know it.
I've heard of menopause, not perimenopause.
No idea. What, huh? What's something to do with women?
My daughters are 28 and 26 and both went to an all-girls school. They got taught nothing about perimenopause or menopause, absolutely nothing.
They usually are mainly just focusing on the pregnancy and the sort of safe sex side of things.
But this, on the other hand, brought a tear to my eye.
I know that it's where your body's getting ready to stop having periods and babies. I know that it's like puberty again and it lasts 8 to 10 years. I also know that mum puts patches on her bum to help with keeping her emotions regulated, and often people going through it will be less tolerant, and often they frame it as really positive power.
So if that's the gold standard, this next one was troubling. Now look, a teenage girl proudly admitted that she had heard of perimenopause and menopause. Tick, great, better than me at 14. But the way it was framed, Dad was the main character. She said she knew about perimenopause because she'd seen memes saying,
Poor Dad. His wife's in peri and his daughter's going through puberty.
Yeah, poor Dad. Oh, I always say it. Poor men. I wish someone would think of the men. Jesus Christ, we have some fucking work to do. Some steadying music, please, Zeke. So what now? Well, now it's your turn. Talk. Talk to your kids, your friends, your colleagues. Say perimenopause out loud until it's no longer invisible. Raise bright minds and supportive allies who expect better for women and AFAB people in midlife. Advocate, write to your MP, show up at workplace policy reviews, fill in the bloody surveys. Don't underestimate how much weight your voice carries when you actually use it. Celebrate. When you find a good doctor, nurse or allied health expert, shout it from the rooftops. Reward the ones who get it right and help create demand for more of them. Participate. If you can, like we said, join research trials, give feedback on health services, sign petitions, add to the data that proves change is needed, because stories backed by numbers are impossible to ignore. And challenge. Always challenge. Push back on lazy stereotypes, on dismissive comments, on systems that don't fit us, on fucking problematic memes. Help build something new and drag a few people with you while you do it. Because here's the truth. If we keep quietly soldiering on, it stays our problem. History shows us systems only change when silence turns into consequences, when employers lose talent, when politicians lose votes, when industries lose money, when communities demand better. Real change comes when society, not just women, takes responsibility. And beyond this podcast, I've been marinating on a few ideas. What if menopause was taught in schools to all kids? Puberty gets plenty of airtime, so why not reverse puberty too, which, let's be honest, many of their parents are living through. What if there were doulas for midlife? Honestly, I need that more now than I did in pregnancy. What if there were pre-gyms, safe spaces for women and AFAB people to lift without judgment? And what about a 101 program for partners, perimenopause for idiots type idea? Sorry to call your partner an idiot, but I'm sure you've whispered worse under your breath in the last 7 days if you've got one. If you don't, well done. Practical tips and tricks on how they can actually show up better or show up at all. That one's coming soon. Don't worry, watch this space. I've even roped in a very famous AFL footballer to voice it in the hope that the men will listen. Breathe in. These are half-baked, sure, but things like this would have made a world of difference for me. Have you seen anything similar? Got ideas? I'm starting a Peri suggestion box. Email hello@downthehillstudios.com. We'll collate them and pass them directly on to Senator Katy, or shove them under the noses of people who can make them real. Investors, if there's anyone out there, hit me up. Let's do this. This podcast has been one of the most personal things I've ever done. I've put so much of myself into it. The raw bits, the messy bits, the things I only whisper to myself inside my mind in my most darkest hours, and there's been a lot of those hours. But the response from you has honestly floored me. I'm recording this episode on the 10th of September. We've already got 4 EPs out in the wild, and the comments and the emails and the DMs tell me that you all have found the words to explain what's happening to you and the courage to push back if you've been dismissed. And that's all I wanted. For this podcast to educate, to validate, to ungaslight, and to hand you the tools you need to advocate for yourself. And from what you've told me, we've achieved that. This podcast was one strike against the silence, naming what others won't, validating your story, and hopefully showing you that you're not alone, that you're part of an unstoppable, pissed off, brilliant community that wants more from midlife and beyond and won't shut up until we get it. But just like Leanne Mulheron, registered psychologist, I want more.
I want a menopause Me Too moment where everyone gets up and they just talk about this shit. They legitimise it, they normalise it. You know, people being authentic. This is what we need to see.
A menopause Me Too moment? Sign me the up. So now it's time to wrap this episode up. Those who know me know I'm a musical theatre girly. So think of this as the curtain call to acknowledge all of our amazing experts and guests. Picture them all running out, taking a bow, you giving them a clap, a standing O, of course. And I'd like to ask you to please throw your support behind them and their businesses, their causes, learn from them, carry their work forward. They all volunteered their time to this project. We hope to surface more of their amazing interviews very soon, as there are more pearls of wisdom left on the edit room floor. A massive thanks to my Rage Committee, to What If, and to everyone who amplified the podcast. Please keep it going. A huge and final thank you to my EP, Tara Carlon, who really put this whole thing together single-handedly. She organised the experts, pulled the episodes together, kept in touch with the Rage Committee. She truly is the estrogen to Rage Against the Vagine. And she actually still has estrogen, so we hate her. And a huge thank you to Ezekiel Fenn, but we love her, and this podcast would not have happened without her. You don't understand how much she did. She did the job of 5 women. And a huge thank you to honorary woman Ezekiel Fenn, who I believe did grow ovaries in this process. He did all the editing, he did all the scoring, he composed all the music, and he pieced together every episode like a mad scientist late into the night on some occasions. Thank you both. I love you and I couldn't have done this without you, and they're sitting in the room and I can't look at them or I'll cry. They absolutely saw me at my very worst and paused and cut out snot and changed scripts, and I love them both. I'll be back next week, one more time for this season, maybe a few more. Look, I've had some ideas to lift the lid on my time capsule. Oh my God, I forgot about that till I'm reading this right now. I'm nervous to listen back. On April the 10th of this year, I sat down and had to record my vision for this series. So now it's September, and when I tell you, so much has changed for me since April. But look, I think my intention has never wavered. So here's me throwing to me about what I think. I think the main thing keeping me up is women and AFAB not being aware of their own internalized misogyny around the idea of aging. And I know so many women who are just blocking out this conversation, not absorbing information, specifically saying, no, this is not me, because they feel attacked by the idea that they could perhaps be in perimenopause or menopause. And the idea if you feel attacked about something that is biologically natural and that happens to everybody, if you feel like that devalues you in some way, that is your internalized misogyny and the systems that patriarchy have set up in play. So it's a really complex situation that I can make the most beautiful podcast in the world and I can deliver all the information I want, but if women are recalcitrant into it or just completely not wanting to take it on board because they don't want to be associated with it because we don't allow women to age, then I'm screaming into the void. So the main function of this podcast is to reach those women who are struggling in their life but refuse to or feel threatened by putting it in the category of hormone issues. All right, the script says that I'm meant to end with past Em, but it's present Em, back on the mic. I needed to have the last word, but I don't really have anything to say except I can't believe this is over. And I'm really glad you all liked it, and please keep sharing it. And also there are going to be more episodes. We've just got to find some sponsors. Maybe we'll have another t-shirt drive. I don't know. But I interviewed 20 plus experts and there is tens of hours of incredible knowledge that I need to get to you in Series 2. I'm calling it. We're going to call it The Experts. It's happening. I've just got to find the cash. You know I'll find it. Thank you again to everybody who volunteered their time. I don't want it to end, except it must. Goodbye, and please keep the productive, reproductive rage going. This has been a Down the Hill Studios production, created and voiced by me, Em Rusciano, with my incredible team. Rage Against the Vagine is made to be shared, replayed and used as a resource, especially by those who need it most. If you found this episode helpful, please subscribe, rate and leave a review. It helps us reach more people who need to hear these conversations.